Does the phrase palliative care make you a little uneasy when it comes up in your clinical practice? You're not alone. Serious illness conversations can feel intimidating without the right tools. Tune in to gain practical strategies from a palliative care team to share how interdisciplinary care works, a framework for serious illness conversations, and why SLPs are vital to the process. Welcome to Speech Scope, a MedBridge podcast where we conquer challenging topics for the medical SLP. Our aim is to deliver actionable takeaways for clinicians like you through captivating discussions with experts in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, Sarah Baar, a clinical SLP in Michigan with over 15 years of experience. I specialize in adult neurogenic disorders and the life participation approach. Today, I'm excited to be joined by Marta Kazandjian, SLP, and Dr. Cynthia X, experts in the area of serious illness, palliative care, and working successfully as a team in palliative care practice. We'll be diving deeper into this topic, including recent research and actionable takeaways you can implement right away. Marta, we'll start with you. Thank you so much for being here today. Can you get us started by sharing a little bit more about yourself and how you're involved within palliative care?
Thank you, Sarah. I'm really excited to join you today with my friend and colleague, Dr. Cynthia Pan. So I am a medical speech pathologist. I've been practicing for over 35 years. I'm board certified in swallowing and swallowing disorders. I'm an ASHA fellow, proudly, and I have had the opportunity to have experience across all settings in medical speech pathology. Um, I also have sort of a unique recent certification in the last several years as a fellow in person centered care through Plaintree International, which I think was really exciting to represent our field in person centered care. Um, Back in 2015, I went back to school to study integrative whole health at University of Arizona's integrative medical program through the medical school there. I was one of the first speech pathologists to be admitted to the program there. And I started to really learn about this concept of the whole person, whole health, and to learn critically about what that looks like. My professional work has really focused on critical care, working particularly with tracheostomized and ventilator dependent patients, and that really aligned me with palliative care and learning about patients with serious illness. And so from there, I was invited to share my work, collaborating with palliative care teams across all of these settings, and at many teaching institutions and national conferences, which has allowed me to do the work that I'm doing today, and most recently, co-author the third edition of my textbook, Communication and Swallowing Management of Tracheostomized and Ventilator-Dependent Individuals. It it When we wrote the third edition, my co-author Karen Dykman and I decided that it was imperative to include a chapter on palliative care, particularly after COVID. And so, in that chapter, we wrote about a framework that hopefully we'll have a chance to talk about partners that helps team align in the messaging to ensure patient-centered care. And I have had the incredible privilege to work with Dr. Cynthia Pan over the years to really learn from her and to collaborate both between both disciplines.
Fantastic. Yes. Thank you for your introduction and thanks for bringing your friend with you. So, Dr. Pan, we're so glad to have you here with us as well today, also. So, why don't you tell us about yourself and how you're involved with palliative care and know Marta?
Thank you so much, Sarah. I feel very grateful to be here with Marta. I really think of Marta as my soul sister. Uh, my name is Cynthia Pan. I'm an internist, geriatrician, and palliative care physician. So, geriatrics is focused on elder care, and then palliative care is for patients who have serious illnesses. And as our society is aging and we have increasing amounts of medical technology, it's more and more important to think very thoughtfully and intentionally about what to do when patients become seriously ill. So I went into medicine to really provide patient centered care. And pretty soon after I went into medicine, I realized that a lot of people are not speaking about what matters to them, talking about advanced directives, talking with their families, especially with different cultural backgrounds, so that if and when the patient became seriously ill and lost the capacity to speak for themselves, their families really were at a loss. And that led to a lot of missed opportunities and suffering on all parts, including moral distress for the medical teams. So I met Marta at NYP Queens at New York Presbyterian when I went there to start a palliative care consult program. We had shared many patients together. Hypothetically, like patients who have advanced dementia, who had difficulty swallowing, chronically critically ill patients who had a trach with vent and feeding tubes, sometimes add dialysis to that too. They were going back and forth from the hospital to the nursing home and back. And we always talked about how there are, missed opportunities, and we and the healthcare system together, we can really do better. At some point, I felt burnt out and I thought about leaving medicine altogether because it was just getting to be too much, very emotionally draining. And at that point, Marta really gave me a lot of support, and we began to partner on education together, teaching not only SLPs, doctors, other providers, ways to start advanced care planning discussions around serious illness. And then I had gotten a grant, and we kind of work together on a course together called ADLAST, which stands for Advanced Directives Live Action Simulation Training, where Marta and her entire SLP team participated in team learning with various other disciplines. And that was really, really gratifying for everyone to learn together and collaborate about how to broach the serious illness discussions together. And I'm also very proud to share that I recently published a new book that's more public facing called Exit Strategies Living Lessons from Dying People to really start a public conversation about this topic.
Wow. You both have such impressive resumes. I thank you so much for having the conversation with us today. And we'll be sure to link your textbooks, the programs you put together in the handout for the episode. Cause I know as you're saying this, I'm like, I want to go check that out too. So we'll include the link on the handout. Let's start today just by making sure we're all on the same page about the term palliative care. So I just want to hear from you like, what is it? What's the goal? Who's involved? Let's start with the basics.
Great. Okay. So I can start by defining palliative care. I like to use the CAPC definition. CAPC stands for Center to Advance Palliative Care. It's a national organization. And palliative care is a specialized medical care for people who are living with a serious illness. It's a type of care that focuses on providing relief from symptoms and the stress of an illness. Because when somebody's seriously ill, not only is the patient feeling stressed, but the whole family, the whole community, the whole circle. So the goal is to improve quality of life for both the patient and their family community. Palliative care is the umbrella, and then under the umbrella are other terms or services like hospice care, comfort care, supportive care, things like that. And this is really important because, like I said before, our society is aging. We have a lot of medical technology. When older people get sick, it gets complicated. It's not only one problem that you're dealing with, it's like 10 problems altogether. Um, and the goal is to find out what really matters most to each person, to each patient, and focus treatment efforts to align with those values and preferences. And that's a new CMS Medicare age friendly imperative, also. It's a quality metric that just got rolled out in 2025. So we think of palliative care as starting with the patient as the captain of the ship. The families play a strong role, supportive role, the healthcare teams. And the doctor, the social worker, the nurse are traditional disciplines recognized as, on the palliative care team. But really, we need to expand the team to include important disciplines like SLPs.
And I've been working really hard to hope that SLPs will become very recognized as valuable members of that team.
Absolutely, yeah, and we'll kind of talk about how you've done that and what might help. I find it really kind of like encouraging that with all the person-centered care focus that we're seeing like Medicare writing initiatives for that into what they're looking at, and because I think that just can give us all confidence that like we're going to keep moving in that direction. So moving to a person-centered approach, it's not like a waste of time. It's how the whole culture shift is going. Um, Marta, we'll go to you. So why do you think it's important for us to discuss this role of SLP on the palliative care team? Like you have been working for a while, so historically, like what have you seen? How have SLPs been involved? Are like what challenges are you noticing or like what hopes do you have for like what we could be on the palliative care team?
Yeah, it's a great and important question because we speech pathologists have a huge role, and I have worked hard to advocate for our role across this recognized team with serious illness, particularly because we're experts in two areas that often are affected for people who have serious illness. Communication impairment as well as swallowing, because they are often presenting signs and symptoms of serious illness disease. And so we are called to address these impairments and across all settings. And my hope is that we can really talk a little bit about that because it's not just in the ICU and in critical care, but across all settings of medicine, transcending into, onto the inpatient units, across long-term care, post-acute care, subacute care, outpatient, home care, et cetera. So, but historically, I think speech pathologists typically, certainly in the acute care arena, are called late to the table, and we're often asked to, we're often called because there is a need to determine a safe PO diet. But oftentimes, when we are asked to see the patient, it's often late when it's really not perhaps even possible to provide a safe PO diet. Um, and so one of the struggles I think that we have is that and what's sort of interesting is that even though we're often called late, the speech pathologist is often called even before the palliative care team or specialist. And so Cynthia and I actually looked at that and were very interested in how the speech pathologist can actually have a role in engaging palliative care earlier. In fact, recognizing that this person has a serious illness and calling them early, like within like the first 3 days of admission, so that we're well positioned to get the team to call the palliative care team and for all of us to get on the same page. I think the other sort of historic uh, thing that I think I've seen in my career is that because we get called late to the game, speech pathologists are sort of forced, and I'm using forced in quotes, to document sort of NPO recommendations that often lead to moral distress, both for the team, the patient, and the family. And so, sort of my hopes for improvement, I love that you're asking that, are that, we all align together as a team to identify patient values and goals to create that individualized patient centered care plan, but with early discussions, particularly around feeding options. And particularly, perhaps, for those clinicians who have an opportunity to work across settings, may, before even their acute admission. And that's some of the work that Cynthia and I did together when some of our patients were actually in a nursing home setting or in a subacute setting, we could reduce hospital admissions because we had those earlier conversations and had a plan.
Absolutely.
Yeah. Can I just add on to that also?
Yeah.
Because speaking of historically, I don't know if you remember, Marta, we had gone to a CAPS's national seminar and we presented our work from the post-acute and we met Diane Meyer and I had introduced you to her. And I think it was a light bulb that went off that, oh yeah, we haven't really been focusing on speech language pathology. That should be a key discipline to include. And then since then, you've done a lot of work for CAPS.
Yeah, yeah. I mean, I was shocked actually that I was the only speech pathologist at that national meeting, with every possible professional that addresses serious illness, and I was the only speech pathologist, and in fact, we were really proud because we actually got an award for that presentation because they were blown away by the collaborative work. And I think it was just like Cynthia said, opening, turning the light bulb on and saying, wait a second, communication and swallowing matter.
Yeah, absolutely. And I think maybe just from my experience working in hospitals, even understanding like palliative care is the big umbrella and it's not like for sure hospice, because I think there's even in my work settings been confusion on like, oh, yep, okay, palliative care is involved. Nope, therapies are done or, like that type of
Mm-hmm.
thing.
That's so
But
important. Yes. I
yeah,
mean, that is so important to mention. And you know what? I often tell
Yeah.
both my students and patients, and when we talk about palliative care, not only do we talk about it as the umbrella, but often we'll say all patients with serious illness are palliative care patients, but all hospice patients, I mean, all patients who are hospice, don't necessarily. It's not the same. It's not. They're not the same. So, you know, uh, I should say it this way, perhaps all palliative patients are not hospice patients, but all hospice patients are palliative care patients. Right?
I got it with the umbrella. Like,
Yeah.
that's good.
Yeah.
And it's really, I don't think everyone is thinking that way yet. So,
You're right.
so, you mentioned that palliative care, this is an interdisciplinary approach. And I was hoping maybe starting with you, Dr. Pan, can you talk about how you've seen this collaboration? Like, what does that actually look like with speech pathology? Um, do you see any barriers popping up or like what to you as the physician, like what's like really helpful for you when SLP gets involved?
Mm-hmm. Yeah. I think interdisciplinary approach is really important. Sometimes people say multidisciplinary. That kind of implies like people working in parallel, but in silos, not necessarily communicating. So I really love that interdisciplinary or interprofessional, which really talks about a two-way communication or even more than two-way. So collaboration works best when all the team members can work together to build a trusting working relationship, which really starts with simple things like introductions, right? So when you're in a hospital, each patient sees on average 17 different providers. They don't know who's who. That's why we have to wear IDs that says doctor, therapist, nurse, because the patients have no idea who they're dealing with, right? So also, if we're working in whatever healthcare setting, it would be really nice to just take that little extra effort and introduce ourselves. So if I can introduce myself to my SLP colleagues or my SLP colleagues who don't know me can introduce themselves to me, then we can at least get to know each other, our backgrounds a little bit. And then when in times of help, when we have these common challenging clinical situations together, it's much easier to call somebody that you know than somebody that you don't know, right? So it starts with simple things like that. And then building that psychological safety to have an agreement that we can talk about hard things together, even when we have disagreements or appear to have disagreements. That we're all coming from best intentions, but maybe somehow there was some sort of miscommunication. And then to also agree that behind the scenes, not in front of the patients, that we'll have time to talk about the clinical situation and come to an agreement and then relay that same message to the patients. Because a lot of patients have told me that, oh, Dr. X comes and says this, and nurse A comes and says that, and somebody else comes and says yet something different. So they don't know who to trust. And what they do is they trust no one. And then they, write things like, oh, nobody knows what they're talking about here because everybody has a different opinion. And that doesn't look good for us and it's not good for our patients. So, really coming to the patient and the family with one cohesive plan.
Fantastic. And then what types of things do you like to hear from an SLP then? So like we're kind of moving beyond them saying hello, but like what helps you, I guess?
Yeah. So I think that in my experience, having the SLP contact me to say, oh, I saw the patient, this is what I'm thinking about. I'm thinking about making a palliative, a recommendation for palliative care to see the patient. Do you think it's appropriate? Or I'm thinking about writing NPO, but I don't think that's right. What else should I be writing about? So we'll be talking about maybe some of the languages and smart phrases that we can work on and just put into our electronic medical record to make the notes a little more inclusive and not just focusing on that NPO, which is not a good option.
And I know also too, Cynthia, you've also asked us when you do get consulted on patients that have communication impairments, or you're not even actually sure what the communication impairment is. You've asked us to sort of assist you with whether they're non-speaking or whether or not there is either a cognitive language impairment or an aphasia, how we can help you communicate with that patient so you can learn more from the patient. And I know that that's been a great experience together.
Yeah, that's so true. When we have difficulty, with patients who have communication challenges, like when Marta first showed me the iLink, I thought it was like, what an amazing tool. And then we started teaching it. Marta came and taught our fellows about it, and we're giving it out as a graduation gift. I never got one. I still need one. Uh,
It's coming
yeah.
for Christmas now that I know that for sure.
And then the other thing that I really learned from Marta, with patients who are answering questions not always reliably, like yes, no, maybe, I'm like, okay. So Marta had taught me a very good trick that I have taught my whole team is that if the patient is not answering reliably, let's say the patient is a gentleman. And now I'm going to say to the patient, now listen very carefully. Here's a very important question. Are you a woman? And if the patient really has, this is okay for non-binary patients. If the patient is a guy and I ask that question and the patient really knows what's going on, they're going to give me a look like, what the, So, no, I'm not. So then I'll know that the patient is really paying attention.
You can kind of like suss it out that way, huh? That's good.
Yes.
I like it. Okay, so Marta, you have to tell us about your partners framework then. I feel like we've been talking about it. So tell us about this partners framework and how this kind of met a need that you saw and like how you use it in palliative care.
Yeah, so I first developed partners, PARTNERS, as the framework to really guide serious illness conversations for patients with communication and swallowing difficulty. So I was really thinking particularly about speech pathologists. But then what I realized is that when you share it with the whole healthcare team as a framework for all of us to utilize, it really started to align messaging across the serious illness continuum. And so, just briefly, partners stands for P for prognosis. So, having working to understand the patient's prognosis with also the understanding that prognosis changes. Our prognosis in the critical care arena may be very different from the prognosis that then with the same patient follows through the continuum, perhaps to the long-term care setting. So prognosis can change, but what is the prognosis as everyone understands it in the moment? A for advanced directives. Speech pathologists have a unique role, along with all medical professionals, to talk about advanced directives, to understand and help our patients understand what that even means, and put it in layman's terms, and to help them, particularly for those who have communication impairment to have them understand what it means if we're talking about a DNR versus a DNI. Um, and then R for risk. What is the risk of the procedures that all of us do? What's the risk of oral feeding in a patient with multiple comorbidities or a patient that has a neurodegenerative disease? So how do we individually within our disciplines and then collectively as a whole as a team look at risk? Um, and that's really where I think about the concept of whole health and the whole patient, because it's not just what's the risk. And in speech pathology, particularly in swallowing, we're not just looking at aspiration. We're looking at what's the host look like? What is their baseline status? What's their functional status? So risk is a sort of a very, very important component. T for talk, because first of all, can the person talk? How are they talking? How do we facilitate talking? And how do we talk to the patient and the family? So, how do we learn the serious illness conversation skills that help us guide conversation to identify and to understand the unique values of the person in front of us? And we can talk a little bit more about that because there's lots of training opportunities for clinicians. It's not a ground ball. It takes time and training, and I've learned a lot from Cynthia and from many of the trainings that I've done. N for non-oral feedings. Are we feeding the person? Are we not feeding the person? What are their risks and values associated with that? E for expectations. What is the expectation of the patient? What is the clinician's expectation individually? And then what does the team expect this patient to look like? And where are we going with the patient? And then recommendations for is our, of course, our particular recommendations after we do our assessments and our treatment regimen. What do we recommend? Is it in alignment? And then finally, S for summary and support. So partners, I utilize that term because we are partners with the patient.
Wow. That's awesome. Love it when a good acronym works out too. Those all fit so well. I can see how this expanded beyond just speech pathology because like I'm just thinking of past situations where I felt more of like that silo, right? And I'm like, I actually don't really know what this person's prognosis is, but I'm not really part of the team. So I just have to talk carefully. And, it's like, I think there could be so many benefits for everyone on the team having the understanding about all those
Sure.
factors. So,
I mean, we've all had the experience where we go and we see a patient, and perhaps the patient was a newly diagnosed cancer patient. Does the patient know their diagnosis? Did the physician? So I often, when I talk about P for partners, P for prognosis, I'll start by asking the patient, tell me a little bit about what the doctor has explained to you about your condition. So I utilize sort of open-ended questions to learn more.
fantastic. Yeah,
Yeah,
there's,
I just want to add on a couple of things because
Yeah,
Sarah, you were saying that you're not part of the team, but in fact, if you are the SLP on a team, you are part of the team. Yeah. And then prognosis is also something like for medicine, there's supposed to be three arms, like a three-legged stool. So it's about diagnosis, treatment, and prognosis. And for most people, including many physicians, the focus is on diagnosis and treatment, not a lot of times on prognosis. So that is a science that is in the middle of developing, and we're trying to really teach a lot of healthcare providers to pay more attention to that.
mm, yep. Yeah, that's a good reminder. We're always part of the team, right? So um do you have any suggestions for SLPs? I'm kind of just imagining when I worked at a hospital, we were right by a cancer center, but separate buildings, and I would do outpatient therapy. So I just had patients every hour on the hour. So I wasn't in a physical space to interact with anybody in the cancer center. And that's where sometimes you just kind of like felt like, I don't really know what they need from me, but I'm kind of just meeting the patient. Um, yeah, I don't know. Do either of you guys have suggestions or
well,
like,
I think it's honestly, I think that's a beautiful, beautiful scenario that you're presenting us with, because I often, I have the opportunity to work across. My program that I lead is an inpatient, outpatient program across inpatients with pediatrics to geriatrics. And the reality is, if you ask the patient, tell me a little bit about what your doctor has shared with you, tell me about what you've experienced, you get a real bird's eye view, and not only their understanding, but what, the doctor may have told the patient that he or she has cancer. But if the patient isn't verbalizing that to you, it gives you the opportunity to then make a connection with not only the referring physician, but the specialists that are involved. And yeah, it takes a lot of time, and we can talk about that because the reality, I'm with you, Sarah. We go back to back with our outpatients, and there's not a lot of time. But the time is well spent when we do make those connections because we have a much better outcome, both for the patient and for us in developing our treatment goals.
Absolutely. Okay, we're going to do a little pause because guess what time it is, you guys? It is the wild card question time. So, going to see a little personality here. So, you guys do work in what I imagine some days are a little bit heavy, kind of a heavy work day. So, we'll here's the question I want each of you to answer. Do you have a song or a playlist that you put on to pump yourself up for a day of work?
Well, I literally am I'm going with my gut.
Yes, go with
It's
your gut.
bum ba da bum 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 ba da bum 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 bum. It's Rocky. It's Rocky.
Woo!
That's what came to me. It's like, put the boxing gloves on. We're going for it. We're getting
Love it.
through the day.
Okay, that's fantastic. Okay, Dr. Pan, what about you? Do you have a song or playlist you like to use?
Yes, I have a whole playlist which I cannot play. But one of my top ones is This Is What You Came For by Rihanna.
Yes.
Yeah.
Okay, those are great answers, you guys. Okay, back to our podcast topic here. We are talking about serious illness conversations. So I want to just dive into like when we're talking about serious illness conversations, like what are those conversations? Like what are the type of conversations that we're having with clients?
Yeah, so serious illness conversation is very complex because in order to have serious illness conversations, first we have to decide what kind of patients are we going to have these conversations with. So that gets into how do you identify patients who have serious illness? And that actually is a evolving science. Sometimes we really just use our clinical judgment. Um, I had a joke from before when I first was starting my palliative care service. Some of the residents used to come and say, "Oh, this is what we're saying. Like, if we have a sick patient, we'll do pan culture, pan consult, and then call Dr. Pan."
Oh,
And then it's very late.
Oh, yeah.
But they kind of had a sense of which kinds of patients were sick. It could be defined by a constellation of rising, number of medical complications or decreasing functional status. The person is not able to do as much as they were able to do before, or increasing use of healthcare resources like going to the ED more, hospitalizations, mega workups, and things like that. And now, more recently, I'm actually working with some of the teams to see if we can use AI, artificial intelligence, to help identify these patients. But it's not like an easy answer. And then there are courses and training resources that we can use to have these serious illness conversations. There are a lot of different ones. But in terms of patient case scenarios, as we talk about cases, we're going to keep it hypothetical and use composite cases. But situations like patients who have advanced dementia, poor oral intake, weight loss, dysphagia, now they're coming in to the hospital with aspiration pneumonia, and then the SLP will get called and do an assessment. And that's really a great time for them to maybe trigger or suggest a palliative care consult to the primary team. and then together with the SLP, the palliative care team, and the primary team to educate the family about what to expect in advanced dementia. We've actually had family meetings where maybe my fellow was sitting in there and just ask the family member, because typically the patients no longer are able to participate. So my fellow actually asked the family member, say, well, do you know much about dementia? Is it treatable? Is it reversible? And here I was thinking, well, that's kind of a dumb question. I mean, who doesn't know about dementia? And then the family member responds like, actually, I don't know. Is it treatable? Is it reversible? So, just starting from the basics and checking in is a very good approach.
Yeah, or they respond and say, "Oh yes, I know all about dementia, and if my loved one gets enough therapy, he or she, mom will get better." And so again, you start to get insight into expectations and
Mm-hmm.
knowledge, and it gives you a starting point. Absolutely.
Mm-hmm.
For sure.
Marta, do you want to talk about like patients who have sepsis, respiratory failure, that kind of
Yeah, I
thing?
mean, certainly we see a lot of patients, and I know we've seen a lot together, Cynthia, where the patient is septic, and then they have respiratory failure. They're unable to wean them, and so we get called because they are really sick, but the team wants to feed them, and then palliative care is called to discuss the possibility of performing a tracheostomy and a PEG, or versus extubation of the endotracheal tube, for example, if the person is for the person that's been critically ill and goes into acute respiratory distress. So we get called to assess and deal with the communication and swallowing, but together we're managing the same patient that's oftentimes, certainly in the critical arena. um
Yeah.
this is a real, but I think one of the things that I know Cynthia and I talk a lot about, and she taught me to think about this, is to think about the functional status of the patient, and ask and talk to the family about, tell me a little bit about what mom looked like a month ago. Or I just recently, I mean, I'm actually dealing with this with my own parent right now. My dad's 93 years old and he's in the hospital, and he looks like he's 73 and has been really great up until recently. And one of the doctors asked me, "Tell me about dad." And I said, Thank you so much for asking me that, because 4 months ago, he's completely independent. He rides his bicycle for 20 minutes a day, et cetera, et cetera." And so it's very important to think and understand the concept of functional status and the trajectory. And sometimes we don't know, and sometimes we don't have someone to ask, but it is something that I know that particularly for, I know you've taught me this, uh, Cynthia, that oncologists use this to help decide, who are good candidates for chemotherapy and other things. So, and we could probably share some of those resources on how to look at functional status and talk about it with our team members.
Yeah, I think that really came across as a huge dividing line, especially during the COVID pandemic when we were having serious illness discussions all day long. We don't even know which direction to run to or turn to. There's so many crises happening in front of us. And the conversations usually went like, what would the patient want? What should we do? There are very limited resources. Everybody's very sick with COVID. And invariably, if the patient was doing well, able to take care of themselves, even working prior to getting severe COVID, the families would say, well, they were doing everything on their own. You have to do whatever medically possible to get them back to that baseline. And there's no other discussion, right? But if the patient was already declining and kind of failing a little bit, kind of a downward trend, then the families would be very understanding and say, yeah, they were already not doing well before. And now with COVID, I can anticipate that they're probably not going to do well. So functional status is so important. Not everybody realizes that. Not everybody asks about that, but it's a very important factor.
Does this look like between like your two disciplines? Like, is there like rounds that happen, kind of like ICU rounds, but palliative care, or how do those communication moments happen between the disciplines that are involved? Because I'm imagining as the SLP, I'm like, oh yeah, this type of situation is so complex, right? And so when does that communication happen?
I think it depends on the setting, when and how. I think in the ICU, we often are considered, we're the consultants coming in, and that so is the palliative care team. And so it's an opportunity to sort of, especially when you've developed a relationship with the pal care team, sort of spending some time to talk about the case after each of you have seen the person independently. And then after you've seen the patient and you have a plan, also debriefing after that experience so that the rest of the team and the palliative care team along with the medical team and the allied medical team understands what transpired. So in hospital settings it's probably a little bit easier, but I know that recently I had a patient here, who clearly is a serious illness patient, palliative patient. And so I had to seek out the community palliative care team to ask, how can you support this patient as he's, continuing on this journey of neurodegenerative disease?
Yeah, but I like, Marta, how you're really getting us to think about like we can be the first person to like get someone plugged into palliative care also.
Yes.
Mhm.
Um,
I agree with Marta in that it is setting dependent. Like when you're in the hospital, it's much easier to run into people and kind of form a team, or maybe set up like more intentional debriefing around difficult cases, or just calling people up. Even in the outpatient setting, I guess you can either epic chat or call somebody up for a curbside and just to understand the situation a little more. And just say, hey, I'm the SLP. I'm part of the team. I'm seeing this patient. Can you give me a little more background? I want to say this to the patient. Does that align with what you're thinking?
Thank you. Just in case people are unfamiliar, or maybe they've been like, oh, it says palliative care, I'm not going to be involved. Marta, can you talk about what are like then the type of things, if someone is under the umbrella of palliative care, what is an SLP maybe working on? Like, what does that look like?
Uh, so, I mean, in terms of, what
Like
kind of
the
patient?
goals. Yeah. Like, what are the types of goals that might be set if the SLP is
Yeah.
working within the palliative care team?
Okay. Gotcha. Gotcha. So obviously we're going to focus on communication and swallowing goals. I mean, because that's our purview. And so maybe a communication goal, I think before I even tell you what goals I'm thinking about, I think it's important to mention, Sarah, that sometimes the medical and the palliative care team might not even know what we offer. And so that's so there takes education on both parts, but providing, let's say, they do know, they've consulted us because, for example, the patient can't swallow. Perhaps, we would write goals, or we would think about perhaps maybe modifying food and liquid textures and recommending compensatory strategies such as positioning, oral care, to provide, to support a safer and maybe sort of a pleasurable quality of life oral intake that's in alignment with patient identified preferences. And so really consulting with the rest of the team, like the dietitian and the primary and palliative care team. So we're not signing off on the case. We're actually very actively involved in the case, but within sort of the patient centered goals. And so working to understand what those values and goals might be. On the communication side, it's identifying and implementing the most practical and reliable mode of communication for the patient, with both their current status and certainly in neurodegenerative disease and anticipated future ability. So whether it's spoken language, moving to communication boards, or the eye gaze communication system like the iLink that I had developed for use not only in an ICU setting, but for patients who are quadriplegic. And I developed it really in the ICU because of trach and vent patients, learning yes, no signals, things like that. But ultimately, our goals are to assist patients in expressing those emotions, their concerns, their wishes regarding their illness care and legacy. And even, I've worked to help promote life review process to guide care planning so that together as a team, we really are creating a very individualized care plan, but we're still staying within our scope.
Mm, excellent. Thank you. So, we have talked a lot about this interdisciplinary care. And when I was thinking about this episode, I was like, one of the things is that the family members are kind of part of the whole team too. And that is something that has felt tricky to me in the past, just because when we're thinking about those like serious illness conversations, kind of getting in those like messy family dynamics at times, or it's just like that another layer to go through. And so I don't know. Do you want to talk about how you handle that?
I could think about a hypothetical case that, that might look something like you have a patient with let's say a diagnosis of ALS, and the person is tracheostomized and ventilator dependent, and they're anarthric, they're quadriplegic, they have a peg, and um, and the the patient is really not able to communicate uh, ec- more than yes no response, because that's really all the patient, the patient looks up for yes and down for no, something very simple that maybe somebody other than the speech pathologist even. And then we get called to help this patient communicate more extensively, but really the staff and the family are um, not really asking all the questions. They're just asking sort of basic questions, yes and no. And so then the speech pathologist becomes this voice for the patient. So if it's using, let's say, an iLink for reliable communication, now the person is able to express wishes. And so what sort of has in the past, because I've experienced it, or hypothetically could happen to many of us, is that the family and the team may be speaking for the patient when the patient is really we actually have a huge role in being able to provide an opportunity for the patient to really speak for themselves. And so you could imagine that if the family is in their best interest saying, yes, we want you to continue to fight and stay on this machine and be with us because we love you and we know you want to be with us too. And and the speech pathologist gives that patient an opportunity to express very novel, detailed messaging, and that person wants to be palliatively extubated. Imagine the type of emotional case that you're presented with when you're talking about someone who expresses a desire to come off life support. But imagine the opportunity to give that person the autonomy to communicate such a thing.
Oh, man. I have goosebumps from that because also what's at stake if you don't do that, you know?
Exactly.
Wow. Um, okay, I am going to go to our maximum impact here. So, can you guys tell us what would be for SLPs listening your three top actionable takeaways that the clinicians could put into practice if they're learning some new things during our discussion today?
Well, I hope that people will consider practicing and using the partners framework. I had the opportunity to actually provide a whole course through MedBridge with Marty Brodsky, a four-course series, and one of the courses I recorded really taught people the details of partners. But I think it's a wonderful opportunity to use a very simple framework that could be quite profound. So practice using it, present it to your team, and talk about it, and use try to align all of those components together. But the other thing that that Cynthia taught me was to use the pull up a chair method. And the pull up a chair method is to use when you want to include the patient's voice is no longer able to participate in decision making. So we have done that for patients with advanced dementia when we're consulted, and the family doesn't know what to do, and everyone is in distress. And so Cynthia taught me to use this pull up a chair method. And what it is that we say to the family, I'm just going to pull up a chair and we're going to imagine that mom is sitting in it right now and she's able to express to us what she really wants. What do you think she would say?
That's beautiful.
Yeah, it's very powerful. We've gotten situations where the children say, "Oh my God, if she were sitting right here, she would yell at every single one of us and say, 'What the hell are you doing?'"
Exactly.
Maybe it's not always beautiful. Maybe it's terrifying sometimes. I don't know.
Oh, yeah. I think the other maximum impact. You said actionable takeaways is, there are lots of opportunities for clinicians to get training. The Serious Illness Conversation Guide gives you scripted language to utilize that you can adapt slightly for our arena to address communication swallowing, but to also really understand patient preferences. So if you sort of need some help in language, in using scripted language, take the CAPC modules. The Center for Advanced Palliative Care modules are incredible. Institutions across the country belong to CAPC, and I worked really hard with that organization to now include learning pathways specifically for speech pathologists. So you can take courses there in serious illness conversation. And I think that's really helpful. And also knowing the literature so that you can present to the family and the team some of the evidence based information that supports why you're saying what you're saying. And I think probably my third actionable takeaway in my view is work in developing templated language in your EMR, like smart phrases that really guide goals of care conversations. So you could say something like, the patient has a diagnosis of advanced dementia, and as per choosing wisely guidelines that are presented by the American Geriatric Society for post-acute care and long-term care, don't insert percutaneous pegs in patients with advanced dementia. Instead, offer oral assistance feedings. Strong evidence exists that blah, blah, blah. And we have used these smart phrases. So clinicians just use the smart phrase. There are goals of care management sort of goals that we actually have in our EMR, and that include things like comfort. If comfort feeding is aligned with patient and family goals of care, consider the following comfort feed guidelines, like position the person upright, provide food and liquid when the patient is alert, provide aggressive oral care, etc. So there's a lot that you can do, and these three things really can make all the difference.
Yeah. I wonder if we might be able to pull in some of those in the handout just so people can see some of those phrases and just
Happy to
like a couple
share that with
sentences
people.
because, yeah, it just kind of helps me- SLPs. I know like that type of thing because it's like, okay, I'm like showing the education and critical thinking behind what
Yeah.
I'm recommending.
So you don't feel, that you're going in and you're getting called late on a case and the patient clearly cannot eat by mouth safely. But we all recognize that. And so it's really, getting everybody on the same page and yet providing care.
Yeah, I especially like that number three, templated language, because it's a great opportunity to educate our colleagues. People might not take CAPC modules or others, but everybody's reading the chart who's taking care of the patient. So it's a great way to just educate our colleagues also.
Fantastic. Thank you both for sharing your wisdom and your tips about this kind of difficult topic today. So, as we wrap up, do you have any final words of wisdom or inspiration that you want to leave with the audience?
Well, teamwork makes the dream work. So get to know your palliative care colleagues and really make those connections. Invite them to lunch or do something so that together you can learn from each other and partner to provide the best care.
Yeah, I also encourage everyone, from a educational, professional education standpoint, to out of this whole talk, maybe choose one actionable item that you really want to implement right now. Because otherwise, once you walk away, you're going to say, oh, nice talk, and then forget about it. So commit to one actionable item.
Excellent. Thank you both so much for taking the time to share with us. And Marta, Dr. Pan, it was really lovely to chat with you and learn the clinical takeaways related to serious illness conversation, working as a team in palliative care. And I know, just like me, I know many SLPs are excited to learn more about this topic too. Thank you.
Thank you
you,
for
Sarah.
having us.
Thank you for tuning in to this episode of Speech Scope by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Speech Scope also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com.